let's get started. Hello, everybody. Welcome. We're so grateful to have you here on your lunch hour to listen to the CME on updates in asthma and coronavirus or COVID-19. And we welcome Dr. Samuel to our network, and I'll let him take over the mic and introduce himself and lead into the presentation. Oh, one more thing, very important. Forgot about this. The evaluation. I will be sending you all an evaluation for this CME at the end of the session. So following this session, I'll put the evaluation link in the chat box. Please take your evaluation. In order to receive CME credit, you have to complete an evaluation, and you'll get your certificates of attendance by next Tuesday or Wednesday. All right, thank you all.
All right, thank you, Jana. So my name is Joshua Samuel. I'm one of the pulmonary and critical care physicians here at Sutter East Bay. Been here with the group for about a year now, and just wanted to kind of get involved and get to our primary care providers here in Alameda County and just kind of get to know you guys, give you some updates in asthma and COVID-19 as we're all dealing with this together. So thank you so much for the opportunity, and we'll get started. So first of all, financial disclosures, I have nothing really to disclose. This is part of the Community Health Center network, and this is kind of the disclosures that I need to show you all and tell you all about. These are the learning objectives that we're going to cover today. We're going to talk about the updates and the diagnosis of asthma. We're going to review the data on COVID-19 and its impact on our community, and discuss therapies and kind of the long-term complications and the things that we're kind of worried about in our populations long-term and what we need to consider. So again, just an overview. We're going to talk about asthma here in California, the phenotypes of asthma, the diagnosis and FeNO. What is FeNO? We'll go over that. Some updates in the treatment, and then we'll switch gears to kind of talk about COVID-19 here in Alameda County. And is there certain treatments that we should be focused on for primary care? And again, is there long-term damage that we need to really focus on for COVID-19? So this first slide here is just going over kind of prevalence of asthma here in California compared to the US. I hope everyone can see my pointer. I'll be using this. So if we had it, things I want to focus on here is just the fact that there is a bimodal distribution between the young teenage and young adult populations. Kind of in your mid-years, you kind of go through this kind of stability, quote unquote, of asthma, or not too many increases in the prevalence. And then it can come up in the middle to late age groups. And California, as compared to the US, is otherwise near the equivalence of the US. And also, however, in children also, it's quite less or a little bit less than what it is in the US. Now, when we look at, again, hospitalizations, again, there's a bimodal distribution. So for young children and then teenage years, they don't really deal with hospitalizations, and even middle-aged folks. But as you get, the older you are, you tend to have more hospitalizations, which, again, is specific to asthma. The other thing that I thought was interesting, though, is when we look at deaths and mortality, when we bring in race as a factor, surprisingly, it's just across the board here in California that the asthma mortality rates are higher. Now, I'm not from California or haven't done my training here, so to make some calls as to why that is, I don't know. But I will definitely say that, to me, the environment, and as we all know, the wildfires and the air quality here is definitely different. So we'll talk about how the environment plays a role in asthma, and that could definitely be a contributing factor here also. So now when we look at Alameda County, for just at the data of the prevalence in this county, again, compared to California, so we're looking at Alameda County in blue versus California in orange. And the prevalence here, again, is more predominant in the teenage groups and the younger generation than necessarily the elderly as compared to other counties in California. So that's from the California Department of Health departments. So kind of the same throughout Alameda as compared to California in general. So let's switch gears a little bit to the pathophysiology of asthma. So the first thing always is genetics, right? So there are certain genes and epigenetics that are, kind of preclude people limit people to having asthma or predisposing them to getting asthma. Then you have the gene expression and kind of this whole concept of a microbiome and inflammation. And I think this is the key as to California in general, is what is the environment that we're putting ourselves in that can trigger asthma. And some of those are usually, at least here, is definitely air quality, pollen, the fact that we're right here on the West Coast. Usually you'd think that some of this is protective, but I think specifically here in the Bay, when we know that we have this kind of fog that we see roll in, I'll never forget when I moved in and just saw fog. I was like, whoa, this is intense, and there's layers of it. So definitely there is something about the air quality that I think can lead to this whole concept of inflammation in the environment. And the issue and what we're concerned about is that with severe asthma is, or even asthma is progressing, is this whole concept of remodeling and bronchial hyperresponsiveness. And that has to do with this airway histology here of this is a airway and alveoli. And as you see here, the proliferation is this kind of area around the airway is the smooth muscle is just proliferated. And that is what is the concept of remodeling and bronchial hyperresponsiveness, is the smooth muscle layer of the airways get thicker and thicker the more frequent the exacerbations or when we don't control the asthma. And this leads to things that go from asthma, which is a reactive or a reversible airways disease, to unfortunately things that become more chronic and things like that can progress to things such as COPD, chronic obstructive pulmonary disease. And why is this important? Because it will reduce your lung function. And eventually the patient has all those symptoms that we know of coughing, wheezing, shortness of breath, chest tightness, can cause shortness of breath and reduce their quality of life. And that's why it's so important to kind of cut this cycle and break the cycle. This is again, this is a great slide of showing kind of what severe asthma and what do we know about the cytokines and the phenotypes. This is really, I want to focus on the phenotypes of asthma. And why is that important? Is because we know now that there's two pretty distinct phenotypes of patients who have that classic asthma presentation of alert allergies and atopic dermatitis. They have allergies and asthma as a child, and usually they kind of grow up out of it in their teenage years, progress to adults where they can be otherwise okay and feel like their asthma is well, and then it can come back whenever they have certain viral infections or when the air quality is bad, such as now. This is what we call the Th2 phenotype. And the reason that's important is, as you see here, there's a lot of different cytokines here that are released. They work on B cells, mast cells, eosinophils, leading to histamine release, and which leads to this cascade of increase of nitric oxide and oxidative nitrous stress. This will be important as we talk about some testing that we'll do later on. And there's upregulation of these enzymes here. The nitric oxide synthase is an important one that leads to more oxidative stress. And it kind of creates this cycle of increase of the smooth muscle wall here, where you get increasing growth factors, obstruction of the vessels, and increasing of the airway smooth muscle, which leads to this chronic progressive obstruction. However, there's also this other side where this is, again, the Th2 is the more allergy type, the classic asthmatic that we think of. But there's also this other type of Th1. If any of you have ever had that patient that sounds like an asthmatic, but doesn't have necessarily the allergies or doesn't have the environmental exposures, they might be smoking, but their pulmonary function tests don't necessarily show obstruction. And you feel like this kind of sounds like asthma. But when you give them the albuterol inhalers, when you give them the steroids or even oral steroids, they don't seem to work that well, or they don't respond that well. And that's because we know there is a different type, there is a different phenotype of asthmatics, and that's the Th1 type, where there is this upregulation of neutrophils. And it's not necessarily the histamine release, but it's a working of interferon gamma and TGF-beta that leads to more smooth muscle wall proliferation. And that's why the classic asthma treatments might not work so well for these type of patients. So it's important for us to try to differentiate them. And that's where some of the workup, which we'll describe here in a moment, is important. So how do we diagnose asthma? It still remains a clinical diagnosis, meaning it's all based on the symptoms of coughing, wheezing, shortness of breath that are intermittent in time and intensity. And there is suggestive or helpful diagnostic tools where they should have variable expiratory airflow limitation, meaning if you get pulmonary function tests that show a reduction in FEV1 or any evidence of obstructive lung disease. The key in the classic medicine board question is, what is the diagnostic test for asthma? The answer is actually methacholine challenge, because you want to know, is there inducible bronchoconstriction? And that's what the methacholine challenge does. We give them inhaled methacholine, and we measure their forced expiratory volumes, the FEV1s, and monitor it over time to see if, as we increase the dose of methacholine, is there an increase, reduction, or more obstruction that can be elicited. And the other thing is the bronchodilator. So with albuterol, is there a change of 200 milliliters or a change of greater than 12% when they're given albuterol? That's the other useful tool for helping diagnose asthma. The last thing is this new concept of FeNO, which stands for fractional exhaled nitric oxide, which we'll go over here in a moment, but it's basically measuring the exhaled nitric oxide with which, based on studies, have actually been updated as part of the diagnostic workup for asthma. And I'm glad to say that all these tests are covered by Medi-Cal, and we offer all these tests in our clinic to help diagnose asthma. So how do we classify asthma? This is also important. I think the main thing we want to focus on here is the fact that there's intermittent and there's persistent, right? So the intermittent folks in this column here are the ones who have symptoms that are less than 2 days a week, less than 2 times a month of night waking means, don't have to use their albuterol inhaler that much. It doesn't really bother them, and they don't really have that many exacerbations, meaning less than 1 a year, okay? And these folks I rarely actually see as a specialist, because our primary care docs and providers do such a great job of caring for these people that they rarely ever make it to a pulmonologist. However, the persistent folks, which these are usually where my referrals live, is trying to determine, where do we stand? Are we mild, moderate, or severe persistent asthma? And this is based on their symptoms, their bronchodilator use. Are they using it every day, multiple times a week, several times per day? How limited are they? Is it limiting their daily activities? And is it minor, some limitation, or extremely limited? And also the exacerbations, right? How many times have they had to go to an urgent care and ER? How many times have they need oral steroids? The reason this is important is because not only is this a reason to think about the therapy that they're getting, but it also increases, as it says here, the annual risk of exacerbations increases as you clearly go from mild, moderate, to severe. It can affect their forced expiratory volume and can lead to worsening obstruction if we don't treat them appropriately. So that leads me to this other concept. I think I touched on it, is the fractional exhaled nitric oxide. Why is this important? Is because, we've always talked about asthma as a difficult disease process to really diagnose. There's the clinical forms, but is there a data point or some other test that can really help get us there? And this is a very non-invasive test that has been able to really help guide us, at least not only to asthma, but also about steroids. So FeNO is a fractional exhaled nitric oxide test, where nitric oxide is a natural gas exhaled by all humans, but it's increased specifically in the Th2 asthmatics, that phenotype I was describing, where it's upregulation of this nitric oxide synthase, and you get increased nitric oxide levels. And so this process of increased nitric oxide, literally, we ask them to breathe into a device that measures their exhaled nitric oxide. And the reason this is important is because that measurement helps predict responsiveness to steroids. So we can say, okay, based on these levels, is this patient going to respond to an inhaled steroid? Will they respond to oral steroids? It's also great to get a baseline measurement to find out, okay, this is where you are today. And the reason that's important is because if we do start an inhaled steroid, that we can monitor them and actually track kind of adherence, and is there a response to these inhalers. And that's been showed in studies. Here's a study where they kind of help measure, okay, what's normal? How do we know what's going on here? And what this study did was they took 2,200 patients who had stable asthma, and they noticed that the patients who had or responded well to steroids had a exhaled nitric oxide level of around 45 parts per billion. So the average measurement was right here in the middle, around 25 to 30, okay, was the average measurement. So this helped create kind of like a standard measurement. Okay, this is what the FeNO looks like and how we do it here in our office. It's a little device that we ask them to sit up straight and kind of just blow out easily into. And they have to create a steady expiratory flow rate. And they measure over about a maybe 6-second period the exhale nitric oxide. And then it spits out a number in parts per billion. Normal is less than 25. Anywhere between 25 to 45 suggests asthma. And then definitely if it's over 45, it's highly suggestive of asthma and that they are most likely to be responsive to steroids, whether that's oral or inhaled. And that's very important for us as pulmonologists to know, okay, look, this is asthma, it's very typical, and these patients will respond. And it's a good data point for us to track. Think of it almost like a peak expiratory flow that we normally use. This is something we have at our disposal here in our clinic that we can easily use for our patients and track over time. So it's a nice data point to have. The other things I wanted to point out here, I think that's about it for the FeNO, yeah. Okay, so the next steps here, we're going to switch up to, one thing I did want to mention, that's right. It is covered by almost all commercial payers, and Medi-Cal and Medicaid pay for FeNO also. So it is a paid for test, which is nice for our patients. Okay, so next we'll talk about therapy. So this slide here is kind of, I'm sure hopefully you've seen this at some point, is the step-up therapy approach to asthma. So we always start here with the intermittent asthmatic, where you have your preferred short-acting broncho beta agonist, something such as albuterol, and this is just for the intermittent asthmatic. And then, as you notice, if they have worsening symptoms or exacerbations, the first thing to always do, if you're thinking we need to step up therapy, is first check the adherence. Check inhaler technique. I can't tell you how many times I just sit here and go over inhaler technique with patients because it's so important, right? If they're not able to do the inhaler properly, they're not going to get the adequate therapy they need. The environment. Are there certain triggers that they're chronically being exposed to that are something that can be preventable, such as cleaners, rugs, carpets, things that in their house that if they get rid of, their asthma might be better under control. And then any other comorbid conditions. Obesity is an issue nationwide, and definitely there's a big component of obesity, depression, anxiety, all those things that kind of can ramp up your respiratory rate, can make your asthma worse. So those are important things to assess before you step up therapy. And so this is the kind of stepwise approach. You go next to the low-dose inhaled steroids. If that's not cutting it for them and they're still using their albuterol inhalers multiple times a week and they feel that their shortness of breath, wheezing, chest tightness is not helping, that's when you step up next to the inhaled steroid plus LABA, long-acting beta agonist, and then a kind of continued stepwise approach here. Along this step 4, 5, 6 is usually where I come in as a pulmonologist. I usually get these referrals here where they're on their ICS LABA combination inhaler. They're on Singulair or possibly some of these other drugs here like theophylline, and it's just not cutting it, and they need to know how else they can be helped. And that's where we kind of come in, and where the new therapies and what I want to talk about or focus the rest of the time about asthma is on these biologic therapies, which are great, have come to fruition maybe since the early 2000s and have shown great results for a lot of our patients. The last thing before I go on is to always consider about step down. We have a lot of people who come into this moderate persistent asthma and they do well. They have seasons where they do well or years where they can do well and they just remain on an inhaled steroid. They don't have to remain on that. If they're well controlled and it's been 3 months, feel free to kind of step them down. If they're on an inhaled steroid and they're doing 2 puffs twice a day, it's okay to say, okay, try 1 puff twice a day. Oh, you're doing well in the past couple months? Okay, let's do 1 puff once a day. That's okay to try to step that down. And eventually, if they get down to just an albuterol inhaler alone, that's the goal, right? We don't want them to be on these therapies for longer than they need to due to the side effects of some of these inhalers. All right, so what are these biologics? What are the new therapies out there? These are the actual drugs that are approved by the FDA. They're listed here. Omalizumab was one of the first ones. It's the anti-IgE. IgE is a level that we check. It's related to eosinophils regularly for our asthmatics. And the reason was because this was one of the first biologics that came out. Based on a certain IgE level, if they have certain allergens, they would qualify for biologics such as omalizumab. These other ones here that are listed here, mepolizumab, resolizumab, benralizumab, and dupilumab, are all monoclonal antibodies, as the name suggests. And they work on certain cytokines, okay? Which here, as you can see, the main thing here is, again, the Th2 type. So eosinophils is the main marker that we have to measure here. Is there a certain sense that their eosinophil levels are high? The minimum level is 150 cells. It can be as high as 300. And we'll go over some of the data here as to why that's important. But just to show you again a diagram that the omalizumab blocks IgE, which works on B cells and mast cells, whereas these other biologic therapies work on the certain cytokines that trigger or lead to the downward cascade of cytokine release and inflammation. Again, this is just a list going through the different drugs and the therapies. Some of them are 2 or 4 weeks, depending on which one we choose. Again, I have no disclosure, so I have no connection with any of these. We use them all. And it's really just dependent on the dosing, what the patient, we go over this with the patient to discuss each side effects and what works best for them. And they are approved not only for asthma. So as you see here, there is some of them that have been approved for eosinophilic granulomatosis with polyangiitis. Other ones are approved for nasal polyposis. There are some for atopic dermatitis. So there are other indications for these, and it's not just for severe asthma, but these are the ones that do have the asthma indication are listed here. So let's go over some data. This is dupilumab. Dupilumab is a monoclonal antibody against IL-4 and 13. This is a randomized controlled double-blind placebo control study. There was 210 patients who were already on oral steroids and had 2 controlled medications with 1 exacerbation in the past 6 months of being in this trial. And so they were already found to be the Th2 phenotype, meaning that they had a minimum of 250 eosinophils, an elevated IgE, or that FeNO level we're describing. And what they were looking is the primary endpoint was a reduction in oral steroids from 50% of the baseline after 24 weeks. And the secondary endpoints were improvement in the FEV1 or forced expiratory volume and reduction in hospitalizations. I think this is key. We have so many patients who are on oral steroids, and as we know, can lead to pretty significant side effects of long-term use of diabetes, osteoporosis. It can kind of make them feel irritated, put on weight. So it's important to try to get these patients off of the oral steroids, and that's what these drugs have really been shown to help and benefit. So here's the data, and what we see here is the first one was the primary endpoint when we look at placebo. So those patients who are on their oral steroids, they're on a combination of an inhaled steroid and a long-acting beta agonist versus patients who were given dupilumab, which dupilumab is twice every 2 weeks they needed an injection. And what they noticed is that there was a pretty significant reduction in the dose of oral steroids compared to placebo, which is what their primary endpoint was. Also for me, this is important, was the change in baseline of FEV1. So there was an increase on average of about anywhere between 150 to 220 milliliters increase in their forced expiratory volume in dupilumab compared to placebo, which is, again, that whole conversation about remodeling and reversibility. This is what we're trying to prevent, is a reduction in the forced expiratory volume, improving that obstruction, and they met their secondary endpoint, which was great. However, we have to always consider side effects. And so this table here, the main things that I want to focus on is, was there any serious adverse event, which some of these here they talked about. The other things that they mentioned here was the viral upper respiratory tract infection. My Siri wants to talk to me right now, sorry. Was the placebo group had an increase, let me try to close this here. Well, I guess it doesn't want to do that. So the viral upper respiratory tract. So in a placebo group, that was the major adverse effect. compared to those who did not have, who were on Dupixent, where the viral upper respiratory tract infection was not an issue. The other main things, though, that did happen in the placebo, in the Dupixent group, oh man, all right. Trying to get this to 1 second. Oh, okay, I think it's gone. So, okay, eosinophilia. This is the one I wanted to comment on, was dupilumab had a significant rise of eosinophils, which is interesting because the whole point is that we want to be able to block that cascade down the line. And when they looked at it, what was the reason for that is because there actually was a significant injection site reaction. So the main issue with any of these biologics and what we need to be aware of is that rarely it can cause pretty significant eosinophilia, which in very high levels can cause almost like a severe anaphylaxis or a histamine response. And so what we always do is the first injection is typically we have to be monitored. So we typically do the first injection here in our office or at in a monitored setting where we ask patients to sometimes bring in an EpiPen if they have severe allergies, or we make sure we have an EpiPen on hand. Because this is the one thing that we notice is that depending on the patient, and there's no specific rhyme or reason here, but depending on who, they could have a significant reaction. And it's usually on that first injection. There wasn't a lot of data to suggest that following up at injections causes this same eosinophilia or injection site reactions or anaphylaxis. So we do monitor them the first one. We usually watch them for a couple hours after their first injection. And then most of these injections now are actually self-administered, so they can go home and use it themselves and do it almost like an auto-injector, kind of like an insulin pen is what it looks like. So it has shown great results, not only from the data, but I can just speak towards my patients who I have on them. And they, some of these severe asthmatics are constantly in the ER, constantly on steroids. They've been doing very well on these medications. So the next one I want to focus on is mepolizumab, just to show that it's not just one or the other. They all have pretty good results, and there's a lot of data on all the medications that I showed you there. But this one here is mepolizumab, which is a 75 milligram. These are subcutaneous injections. This one is every 4 weeks, and this is a monoclonal antibody against IL-5. This was a 32-week randomized controlled double-blind trial. Again, 576 patients with severe asthma, meaning they were on inhaled steroids and either oral steroids or had recent exacerbations. And this is kind of important because what they noticed, and I didn't focus on all the data on this, but they noticed that between levels of 150 and 300 of eosinophils, they needed to at least be enrolled in this trial. And why that's important is if we look at the actual data behind this trial, they noticed that the patients who are on closer to the 150 end did not have as significant improvement, meaning reduction in their oral steroids or reduction in hospitalizations, compared to those who had higher eosinophil levels. So essentially, the bottom line is the higher your eosinophil count, the more likely you're going to have a good response to these biologics. So for me, one thing I always recommend is definitely refer over if you have a severe or someone who you're not or concerned can have uncontrolled or moderate to severe persistent asthma and is on their controller therapies, using them regularly, and they're just not responding well. These are some of the tests that we do normally is get the pulmonary function test, get a baseline chest x-ray, check their eosinophils and see where they're at. If you're on oral steroids, sometimes these eosinophil levels will be lower because you're on the systemic oral steroids, which can falsely lower your eosinophil counts. Not falsely lower, but that's the whole point, right? You want to lower the eosinophils, you want to reduce the inflammation. So if they're on steroids and get it checked and they're normal, that does not mean they might not qualify. They might just have to be off the steroids and be checked and see if they qualify for some of these medications. And so the end result for this trial was there was a 53% reduction in hospitalization. And as we know, that's a huge reduction and just a benefit not only to the patient, but the healthcare industry and hospitals. Reducing that load of hospitalization is huge. So again, just great results around these biologics. Okay, so I didn't ask this before, but I'm going to switch up to COVID-19. I'm not sure if we should just wait till the end to take questions, or if we want to take a small break. I can kind of go through this, and I think we can leave like maybe 5 to 10 minutes to go over any other questions or concerns that folks have. And so this COVID-19 update and what I want to go through is mostly just looking at the data for Alameda County. And I wanted to focus on the relevance to primary care, right? There's been a lot of talk about the kind of post-COVID and what we do with these patients. Unfortunately, we still don't have a lot of data. A lot of this is, and talking to my colleagues that are pulmonary docs across the country, is we're kind of taking it patient by patient, figuring out exactly, is this a long-term complication or is this just a prolonged post-viral syndrome, which we all know about these post-viral cough syndromes that people get, and they can really feel cruddy after an upper respiratory illness that can last 2 to 3 months. Is COVID, as we know, COVID can present in so many different ways. So why are we so surprised that it has so many different lingering effects in different ways? I have patients who come to me post-COVID infections with just fatigue, just extreme fatigue, even though they're not hypoxic, not tachycardic, anything else. Other patients who just have a chronic cough that just won't go away. And then there's the other patients who either were fine when they first got it and their virus has technically quote unquote cleared when they get the swab. And then all of a sudden now they're extremely fatigued, or now they are so short of breath 3 months later. And again, we just don't have the data to say this is that cluster or this is that group and this is what we need to do. But I do have some things, some data points, and we'll talk about some of the things some reports that have come out here that have been concerning, and I'm sure that you as primary care doctors get more frequently than I get. So I want to discuss some of those. So, all right, so let's look at the data just of tests. So this is based on the LA Times. This was published on September 21st. At that date, there was 786,130 cases confirmed, with 15,000 deaths just in California alone. And then when we look at the data of the new cases, so there, as we all know, it kind of sprung up here in April and May. This is when we were all getting worried. Around May time, we thought, okay, we had kind of done pretty well. And then all of a sudden, there's this huge spike. And here in Alameda County, I work at Summit Hospital in Oakland, and I'll say that our ICU got pretty packed, but nothing as compared to what LA County, Orange County, and some of the San Quentin and that area. So for whatever reason, my hospital did not see that, but that was a huge reason for the uptick. It was between Southern California and unfortunately, the nursing homes and jails where some of these cases just exploded, which makes sense, unfortunately, because of the close confinements that people were in. And as you probably know, some of the homes and the families most affected are the lower socioeconomic families, where you have these group family homes or generational homes where it's not just the children, it's not the grandchildren, there's grandparents or great-grandparents or uncles and aunts all living in the same vicinity that end up spreading it like wildfire to each other. And this just kind of shows that in July, early August, there was a big uptick. We kind of dropped. And unfortunately, there was another big spike here near the end of August going into September. And we've done actually decently well. Hopefully we're at the point where we kind of, if we do the things that we're asked to do, we can kind of keep it in this area, if not continue to go down. And this is just sad, the deaths by day, but as you see, it kind of correlates with the new cases and kind of this double peak that we see here. So this is the past 7 days. This was also, I got on September 20th. So this is just a rolling 7-day average. The positivity rate was as high, and definitely I can speak to I'll show you some of our Sutter data also, but as it started out as high as 8%, we thought we were doing well, and then bam, bump back up here to 8%. And this is statewide, but the nice part is positivity rate has been come down to about 2.8%. These are for symptomatic patients also, so just to keep that in mind. These are symptomatic patients, not asymptomatic. So this is actually our Sutter-wide data that I got permission to use from some of our administrators. That they do a pretty good job of sharing this data with us about once a week. And this was also through September 15th. So I want to focus here. This is kind of the labs that we use and the turnaround time of the testing that we do. But here, as you see here, the symptomatic column, there's our ER patients, the inpatients and outpatients. So for anyone who's near the hospital, it's around that 8% number. And then for outpatients, the symptomatic ones that ask us for testing, have symptoms, go to our respiratory clinics to get tested, it's anywhere between 4.5 to 5% here. And this was as high. I remember seeing during the peak, like that middle of August time or end of July, August, was as high as almost 12 to 14%. So it's definitely come down dramatically in the past month. And asymptomatic, although now all patients are down to less than 1%, this was as high as almost close to 4%, averaged around 2 to 3, again, at the peak time. So that's just Sutter-wide data right there. So now let's focus on Alameda County. I wanted to just share some of the data. This is from alamedacounty.gov, their COVID-19 page. And what I want to focus on, there's a couple, again, you see this kind of curve that we've been talking about, where it picked up here, July, August, peak was mid-August, September, and it's slowly starting to trend down. But the two things I want to focus on here are the county, the total cases by age group, and also the cases by ethnicity. So as you see here, the majority of cases are still in our young people, the ages 18 to 30. And then it does decrease as you go along as they increase with age, which is surprising, but interesting. But this is, again, just total cases, right? So we'll show you the death data here in a moment, or the mortality. And the other thing I want to show here is that this, again, just goes to our patient population. So majority of the patients, almost 10,000 of these cases, is in the Hispanic, Latinx community. Asians, even less in African Americans. Here's white people, and then a lot of folks, just based on the data, either were multiracial or did not disclose their race. And the reason this is important is here. There's an overall, it is affecting males more than females, okay? And this is total death rate per 100,000 by gender. And this is the data I really wanted to focus on. When we look back at the African-American data, which unfortunately showed a pretty low positivity or case rate, when you look at the death toll, though, that it took, clearly there's a very higher rate of mortality in African-Americans and Hispanics when you compare that to Caucasians and Asians and other races, which is just devastating. And it just goes back to the whole health inequity that we are all trying to focus on, is that unfortunately there's just this big disparity, not only in the number of cases, even though the Hispanic population got hit the hardest, they definitely have a high mortality rate. But I think the saddest portion here is that even though the African Americans has such a smaller portion of case rate, their mortality rate was of the highest in our county, which just speaks to, I think, is there a ethnicity issue here? Is there other comorbidities? There's a lot of discussion that can go on here, and I think where we really need to focus our time going forward is how do we adjust for these inequities, and how a lot of the reason I wanted to partner with CHCN and kind of go forward with this is that this should not be happening in our county, and what are the ways that we can partner together to make this better. Okay, so, I'm not going to focus a lot on the other therapies like that we focus on in the hospital, right? There's a lot of data that's been published about remdesivir, convalescent plasma, the hydroxychloroquine, azithromycin combination that none of us use anymore. I will say that the standard of care right now is if they're hospitalized and they require oxygen, which is what I'm going to focus on here. Those are the only patients who really qualify for these medications. If they're at home and quarantining and doing otherwise well and not hypoxic and not short of breath, they should self-isolate and do all supportive care, just like we would say for any other viral infection. And so that is the key. And if we have nothing else, I want to focus in on this take-home point. So let's focus in on this trial, because dexamethasone, Decadron, those pills are available that primary care providers can provide. And I'm not sure, I definitely have had patients who have been discharged with the hospital, and then they are told to follow up with your primary care or come see me as a specialist, and they're on oral dexamethasone. And then the question is, what am I supposed to do with this? Do I taper it off? What do I do? What's the data? So let's go over that. This was a controlled, open-label, randomized trial. It was 11,300 patients in NHS hospitals. So this was actually based in the UK. it was all ages. They just did this on COVID. They're like, whoever has it, and we need to find something. So it was pregnant women. Almost everyone is included, all ages. And they did usual care, which is honestly, it was supportive care. There was nothing else added. And that usual care was given to both what we'll call the placebo group, or the usual care group, compared to a group that got either 6 milligrams of IV if they needed it, or oral daily for 10 days. And that was for all comers, right? That was for everyone who came in with COVID. They didn't distinguish anything at the time. They just gave them 6 milligrams of IV. This was usually the patients who were either ventilated or could not take oral pills. They ended up getting IV, but if they could physically take oral, they were giving oral, okay? And again, it was open label, just randomized to getting it or not. So it was somewhat controlled, but not randomized, double-blinded. It was a prospective study. So what they looked here was the primary outcomes was mortality reduction. Is there a mortality reduction at 28 days? And then the secondary outcome was discharge within 28 days. Was there who needed invasive mechanical ventilation? Was there a difference? And was there a difference in death if they are on mechanical ventilation? And so this data here, what I want to focus on is, as you see here, here's the all participants, right? So actually, mortality, there was a slight decrease in mortality for all comers when they're on dexamethasone compared to usual care, okay? There was a pretty significant reduction in the use or need of invasive mechanical ventilation when those patients were given dexamethasone. However, they then subplotted it out and looked at, okay, who were these patients? Which were the ones that really benefited from this? And what they noticed is, here's the oxygen-only group and no oxygen. So there was a bunch of patients who came in with symptoms but weren't necessarily hypoxic, compared to those who did need some supplemental oxygen in some form, whether that was 2 liters all the way up to being intubated on a mechanical ventilator. They just took that subset and looked at it. And what you see here is this is the actual group that showed a dramatic reduction in mortality. When you subselect the patients who did not need oxygen, there was actually an increase in mortality to those who were not on oxygen and got dexamethasone. Why is this? There's no real great explanation, but I would say that most likely these patients clearly didn't need it in the first place. And with dexamethasone, that's a very high dose of dexamethasone, and it could lead to other things, other comorbid problems, such as, if you're on it for 10 days, is there a risk that you're gonna worsen any other symptoms of pneumonia or other infections? Will it increase their blood sugar and cause them to be in the hospital for longer or worsen other comorbidities? So this is the key data that I wanted to focus on here, is that it only really was beneficial for those who needed oxygen. And so this just shows that more outline again. So this is a chi-squared analysis, risk ratio here of invasive medical, of either dexamethasone versus usual care. So as you see here, this is dexamethasone is better or is usual care better. And the only groups that really benefited were those who either clearly needed invasive mechanical ventilation. They benefited the most. And then oxygen, if they needed any supplemental oxygen. So this clearly just pushes the marker to favor dexamethasone. But when you look at no oxygen patients, there actually is a favorability towards usual care, meaning no dexamethasone or nor steroids, okay? And this is just, again, their primary, secondary outcomes, dexamethasone versus usual care. There was an overall reduction. However, when we, again, split it up, it was those who needed oxygen that did the best. There was an overall reduction in days to discharge. Actually, there was more patients who were discharged from the hospital within 28 days compared to those who got usual care. You had a less chance of either being intubated if you're on dexamethasone versus usual care. Again, these patients usually are already on oxygen. Depending on when this trial was, before we were just intubating people right away. There's a lot of data that suggests that intubating people right away does not really save lives or does not decrease mortality. If anything, it increased mortality. So right now we're using non-invasive means as much as possible, whether that's high flow nasal cannula, BiPAP, to prevent mechanical ventilation because of the high risk of death. That's not really delineated here in this data, but that's what we know now. And overall, the steroid group just had a less mortality and less invasive mechanical ventilation. So I kind of want to switch gears. So that's kind of the therapy. So if you get a patient who is being discharged on dexamethasone, the point is that they were probably on oxygen when they were in the hospital. Now they're being discharged, and now you're being asked to manage them. I will tell you, I will gladly see those patients if you're concerned or don't want to or don't know what kind of follow-up they need. How often do you check their oxygen? How do I taper the steroids? Those are all great questions. They just did it for 10 days and stopped. So there was no taper here. I take it case by case. Does your patient have asthma? Do they have COPD? Where maybe it's a better situation to taper than just stop completely. So I would say it's case by case. And so this is really, I think, the only therapy that, as a primary care provider, that you might see some of these COVID patients being discharged on, because they don't necessarily need to stay in the hospital. They can get oxygen at home. They can self-isolate and complete their 10 days of dexamethasone. But this is the reason why they got it. Okay. So that's what I wanted to focus on there. Now I want to switch gears a little bit. There's been this discussion about, okay, I don't know if some of you have probably heard that college football, there was a couple conferences, including the Pac-12 here in California, that delayed or had actually canceled the season. And one of the reasons was because of this study. It was actually just a research letter where they looked at 26 college athletes who had mild symptoms, all COVID positive, normal labs, normal echoes. And they were concerned, okay, is there signs of myocarditis? Is there issues where these patients who were otherwise symptomatic had post-COVID myocarditis? And so what they noticed is that 4 of the athletes had cardiac MR findings of myocarditis. However, there's no baseline, right? They just took these 26 athletes at random, and there's no control. It's just a simple observational. They just took these 26 patients. And so quickly, there was a lot of criticism in the medical societies of, why did they publish this? Why is this such a dramatic thing that's literally causing people to cancel college football and changing the way athletes and even our patients. I'm sure you have patients who are like, oh, am I going to have a heart attack, or what's going on with my heart? I feel short of breath all the time. So it was definitely criticized because, first of all, there are major things where these were asymptomatic patients, and this was just a cardiac MR that was just done. And there's a lot of studies that have shown, and I'm sure you've seen this, where there's other viral illnesses. It's unfortunately, it can happen where you can have the flu, you can have adenovirus or some viral upper respiratory and have a myocarditis or a pericarditis, post-viral syndrome, viral myocarditis, that's what it's called. And so, it's not unique to coronavirus. That's the key. It's just, as in any virus, it can happen. And so it was quickly rebutted, and I actually consulted one of our cardiologists, Dr. Vipul Gupta, about this, and he kind of said the same thing. Myocarditis and cardiomyopathy is a known complication of any viral infection, including coronavirus. So yes, don't get me wrong, there are definitely cardiac issues, myocarditis, and we unfortunately had a patient who died of a severe cardiomyopathy related to COVID. Was not hypoxic, no other issues, came in younger person, and unfortunately it was a biomyocarditis. And passed away. I mean, it can definitely happen. And he's had to refer patients for heart transplant. But again, this is not unique to coronavirus. So, the advice was, if 14 days seems a responsible time to avoid physical activity after a COVID-19 infection. That's part of, I think, even during their isolation times, they should still be isolating. So yes, limit your physical activity with people, limit your overall physical activity until you recover. And then it's okay to slowly advance your physical activity. Don't just go for a marathon run. Start with walking and go from there. And if definitely they seem symptomatic, or if you notice you get a troponin or you get an EKG that's abnormal, definitely refer to cardiology and let them evaluate them and see if maybe this is a post-viral myocarditis that's developing, or pericarditis that needs to be evaluated more. So that's really what I wanted to focus on. I want to give a little bit of time here for some questions. I just wanted to, again, thank you all for the opportunity. Just wanted to focus in on kind of where we fall into this whole role of medical care. It always starts with the patient. They see our primary care providers, and then if you'd like to refer, this is the two newest providers we have here is myself and Dr. Arash Minay. And then it's a collaboration. So some of the things I really wanted to focus on is I really want to hope that we can work together. I know that you guys all have Epic now, which is great. I have seen, I'm sure, some of your patients, and I want to know if you're able to view my notes. Are we able to communicate with messages so that we can, go back and forth and say, hey, look, this patient's doing this, or, how are they doing? Are they getting this medication? And if the referral process is going well or not. So that's that. This is us. This is Mike Minay, or his full name is Arash Minay. He goes by Mike. Andrew Greenberg has been here for some time. He's our sleep specialist. Excuse me. He's our sleep specialist also. So he sees sleep. Mike and I do not see sleep at the moment. Andrew Greenberg and Joanna Cooper are the two that do, but we see all other pulmonary issues: asthma, COPD, pulmonary nodules, you name it. So thank you for the time. I'd like to open it up for any questions or concerns.
Thank you so much, Dr. Samuel. Hi, everyone. This is Dr. Doe. I'm just going to go ahead and help facilitate some of the questions. So we have some questions in the chat box. So the first one, excuse me, is from Suksham. The question is, with the COVID pandemic, how do you propose treating an asthma exacerbation in the office?
Yeah, it's a good question. So clearly, if you're concerned, I would always test, right? If they're having, and this is the biggest question we get, are we seeing patients in our clinic? The answer is yes, we are. We are doing our screening, as I'm sure a lot of places are, of the screening questionnaire, temperature screening when they come to the door. And then, if the patient wants to be seen and not do virtual, then we will see them. Now, a lot of my patients, similar to your question, is they come in with shortness of breath, cough, wheezing. To me, I take it very seriously, because although we are lucky enough as providers to have some PPE, like we have the PAPRs, N95s, goggles, some of our, the screener might not be able to have all that. So are we putting them at risk? So I think it's a very individual question. If you can test them and you're concerned that their symptoms do correlate, if they're having new cough, wheezing, shortness of breath, and they've, been around exposed people, do they qualify for a test? Then yes, test them. If they don't, and this is just their classic asthma, I am seeing them. It would be best if we've discussed this also. Is there a way that maybe they can be seen outside? Is there a respiratory clinic or a tent or something that can be set up to protect not only yourself, but your other healthcare providers and your staff? Can they meet in the parking lot? Can we examine them from there? And outdoor clearly is better than indoor. I'll say in our office, we don't have any special ventilation syndrome set up, or any, air purifiers or anything. So it's just, I do my job protecting myself. But if I'm concerned, I would definitely, if there's any concern, I think clearly if we're not able to care for ourselves, or if you're concerned that this could be COVID related, one, test them. If you're still suspicious that they've had high contact or high risk exposures or contact, I would try your best to examine them outside if possible. And then lastly, always protect yourself with an N95 or goggles or face shield if possible. And then treating them, it would be just like treating an asthmatic like you would anyone else. And if they meet those criteria for oxygen and they need steroids such as dexamethasone or prednisone, I've definitely done it. I've had some patients who have post-COVID, like what I would call inflammatory lung diseases, or cryptogenic organizing pneumonias, different disease processes that do require steroids post-operatively, post-COVID. So, those patients we definitely see with abnormal x-rays and things, and they might not just have asthma. So the answer would be to treat them just like you would anyone else, but take the precautions to protect yourself and your staff if you're concerned that they could have COVID.
Okay, thank you. The next question comes from Zena. Curious what you think about the new asthma GINA guidelines, moving away from SABAs only for rescue and recommending Purine low-dose steroids such as formoterol as a preferred controller.
Yeah, I think it's interesting. I think the goal and why they did that is because we have so many patients who Probably, and what I see a lot is that they don't recognize it, that this is not just, oh, I'm short of breath or coughing or wheezing. I have so many patients who become dependent on albuterol and feel like, oh, my inhaler's not working, right? I hear that all the time. My ICS, my Flovent, my whatever is just not working for me, and I don't use it. I just use albuterol. I think the goal is to say, look, that is not the standard of care, right? If you're using albuterol that much, it's not that we just continue to refill your albuterol and give it to you. It's to say, okay, what is it about the steroid that's not working? Are you a Th2 phenotype? Are you a Th1? Do we need to do some more testing here? Is it the inhaler technique? What do we need to go over that's not working for you? Maybe it is that inhaler. Maybe it's the device. Maybe it's maybe you don't need an inhaler. Maybe you need an ellipta or a different device, a dry powder inhaler. So I think it's more to kind of get us as providers to think about is if they're using a short-acting bronchodilator, maybe they should just be on preliminary inhaled steroids. And that's kind of where I think that came from. Yeah.
Great. Thank you. The next question comes from Tan. Question is, when we're ordering PFTs, is the FeNO automatically done, or do you need a separate order for that?
Yeah, so I would say it's a separate order. It's actually an in-office procedure. So it's something we do here in the office. So if you refer them and PFTs, please feel free to order as you normally were. We do not do PFTs in-house. We have spirometry, but for a full PFT, we send them to our pulmonary function lab. Ours is located either at Altubates or at Summit Hospital in Oakland, or Altubates here in Berkeley. But the FeNO, they don't have that at the respiratory clinic or at the pulmonary function lab. We have it here in our clinic. So it is a procedure we do here in-house. So don't worry about ordering it. Just send the referral over and we'll help take care of it.
Thank you. The next question is from Jason. Question is about how do you feel about office-based monoclonal therapy, or should we only send patients to pulmonary for monoclonals?
Yeah, I don't think there's any necessarily indication that says a pulmonologist has to be the one to prescribe it. No. If you feel comfortable and you feel like the therapies, that the eosinophil counts are where it needs to be, the other testing, for instance, IgE, the FeNO levels, I definitely think it's something that is approved. We work with our Medi-Cal payers. We luckily, because we deal with pulmonary and asthma so much, some of the representatives for these drugs come and help us. Our medical staff is very astute to kind of making sure we send it to the right pharmacies, prior authorization gets done, those kind of things that, I know you guys have enough on your plate that we'd be happy to do this for you. But if you feel like it's definitely something that doesn't need a referral, sure. I don't think there's any restrictions that it has to be a specialist to order it, no. And it's something they can do at home. So it's also not something that has to be done in the office. We do the first one there, and there's auto injectors that the patients can do themselves at home.
Very cool. All right, I know we're at time, but there's one last question, follow-up from Suksham. Would you do nebulizer treatments in the office with a concern about COVID, or send them to the ER or urgent care? And is there any special cleaning of the nebulizer needed afterwards?
That's a great question. I would advise that you do not do it. There's been a lot of data recently, and this is more, again, I'm an ICU doc, so I see it in the hospital where we have gone away from all patients. Because of the fact that there was a higher rate of asymptomatic spread, I feel that there's that risk, right? Even though it's much less than what it was, all it takes is a spike. And if they're asymptomatic, you won't know, right? So why put yourself, again, at that risk in a closed off space where they're not in a negative pressure room or don't have good ventilation? The answer is, I would recommend that you don't do it. And if they need to go to an urgent care or someplace that has the proper equipment and can protect not only their coworkers and staff, but the patient themselves, I would do that. We have not really done it here since. We've done some injections and things, but no aerosolized procedures. That kind of goes back to the FeNO. I've kind of put that on hold because they've been literally, you have to blow out, right? So I will say that the FeNO, although we have it, because of COVID, has kind of thrown a wrench into everything. So I've kind of been on hold even doing the FeNO because they have to exhale pretty forcibly. And it's the same concept for aerosolization and nebulizer. So.
Great, thank you. Dr. Samuel, that was amazing. I learned so much, and Yeah, on behalf of the consortium and the network, we really appreciate your time and lending your expertise to our primary care network providers here. Just a reminder to everyone to fill out a survey to evaluate today's talk. That's how you get your CMEs or CEUs as well. And I don't know if you can see it, Joshua, but there's a lot of thank yous in the group chat. So yeah, we're really appreciative of your sharing your expertise.
Appreciate it. Thanks for the time, and hopefully we'll all stay in contact.
Okay.
All
Take care.